University of Arizona. He is also the vice chair of research for the Department of Surgery. He's authored over 350 peer-reviewed publications and 30 plus book chapters. His research has been funded by the NIA, DoD, and DARPA. His areas of expertise encompass traumatic brain injury, transfusions, and factor replacements in trauma patients, fragility, and equity, diversity, and inclusion. He is a member of numerous national associations, president-elect of the Arizona ACS, president of the Arizona Trauma Association, and vice chair of the Committee on Trauma in the state of Arizona. He's also a member of the steering committee on the National Trauma Research Action Plan, and his passion lies in nurturing the professional development and growth of aspiring young surgeons. I've known him for many years from our time at Shock Trauma, and it is my great pleasure to introduce Dr. Bellal. Thank you so much, Dr. Joseph. Thank you so much for coming today. I really appreciate it.
Thank you so much, and I appreciate the opportunity. And we're finally here. It's been a long while since we've talked about this, and I'm excited to be part of this. So I'm going to go ahead and get started. We have 130 slides to get through, and it's like Smokey and the Bandit. It's a long way to go and a short time to get there, but it'll be fine. I thank everyone for being here today. I'm just going to click on, I have nothing to disclose. Really, the goal and the objective of the entire talk today is to inspire many of you. I wish we were there in person, talking in person. It's a lot easier. I don't know who I'm talking to, but really to inspire the students, the residents, the APPs, the fellows, the faculty to continue to push in this arena. I think this idea of aging and frailty and delirium and how COVID has impacted it really is really our aging older populations, especially in critical care, are the elephant in the room. And it really, we do things because we've always done them, and we treat them like every other patient. But the reality is they are different, and we need to start seeing this. And why is this important, especially for the new generation? Because the aging population is growing. It's the fastest growing population nationwide. And the U.S. Secretary of Commerce comments as the aging population to hit the U.S. economy like a ton of bricks. And I think that's the reality. And if you look at changing demographics in the intensive care units, it's the same thing. ICU admissions by age groups, you can see the gray dot line and the gray solid lines that over time, our ICU admissions and most of our patients are the older adults. And, I'm not sure if this is a surgical critical care or entire critical care, but 41% of surgeries last year, those over the age of 65, and we don't have resources for all of this age group. I think that's important. And life expectancy continues to grow. I mean, older people are growing. I'm a trauma surgeon and intensivist, but what people are doing at their ages is very different, and people are really living. When I moved to Tucson initially, I thought retirement meant coming to die, but it really means coming to live and start over. And so what is the definition of old age? It depends what you read, and there's inconsistent definitions of ages and complications, and does age always the number? And a lot of the research and the reasons why I did this was went down this avenue was I got tired of we have an 85-year-old and we need to stop simply because of an age. And there was differences in 80s and 85 or 70 or 65-year-olds. And I think that was important. And we care because this is who we're going to become. And many of those things, it's impacting our entire system. And the intersection of aging and critical illness, I think, is the highest of all complexities. I see it. I see the CME code, sorry. It's the highest of age complexities. And I think it's important that we focus on this. And you take critical care illness in itself, it comes with so many things, and it's the most complex patients. And then you take geriatric syndromes and you put them together. And I think it's not the young, healthy person that you're resuscitating. This is the most complex of all resuscitations in patients. And it's really an anatomic reaction of patient population. Now, when we think about geriatric syndromes, I think it's important. There's a lot of words and a lot of overlaps and what comes first. And delirium and multimorbidities and polypharmacy and frailty and sarcopenia, you hear a lot of words. They all intercross, but they're all their own entities. And it's important that we focus on each one of them separately. And I think I really want to make sure about that. And overlapping vulnerability factors increase the risk of adverse outcomes, but each of them is different, and we can only do things with certain factors. And I think that's important. And, when you look at geriatric care in the surgical intensive care unit, again, Geriatric patients overall, more respiratory failure, more infections, more myocardial ischemia, more AFib, and more mortality. That I don't think it's a surprise to us that they do worse. The question is, within the geriatric population, is this equivalent? And how do we objectify and predict these things? And we really need an aggressive type of approach to this, including resuscitation, nutrition, and all the things. And when you look at geriatric patients versus their younger counterparts, simply by age, you can see complication rates, mortality rates, and regardless of the system, are there incidents of sepsis in the super elderly, those over 80 versus the elderly versus the general adult populations is way higher. And so this is a very important subgroup because they are the sickest with the highest to lose, the least likely we can rescue, the lowest amount of resilience. And this is what leads us to this. And then when you think about complication rates, but we as intensivists all have to get graded on how well we do in our outcomes. And for the young people in the crowd, I will tell you, there's going to be a day where you're going to be getting a grade card on how well you're able to manage patients. And some of it is patient-related factors that we're not going to be able to change. But whether it be urological, cardiac pneumonia, you can see 1 in 3, 1 in 4 patients in every geriatric patients, you see these things. And then you think about the comorbidities on admission, 57% of patients admitted in this subgroup have hypertension or heart failure. And these things, again, comorbidities are one part of the equation. And so when you think about patient factors in the ICU, we are actually not trying to blame the patient, but there are some things our patients come with that we have no control over that are impacting their outcomes. And we need to understand these and understand how to do it. And so there's no doubt that aging does matter. I don't want to go away from that. The chronological of aging, your system, your body changes. But the consequences of aging differ from person to person. And that word aging as a verb, all of us age differently. And there's reasons for that. But, older age patients have differences in neurocognition, cardiac function, and all the things that we need to deal with and resuscitate. And these are some of the changes we see across the 3 main systems, whether it be cardiovascular, pulmonary, renal. I mean, they are just a different subset. And again, understanding which patients have these changes. Not all old people have this just because they're like that. And I think that's important. But this leads to devastating outcomes in older adults, especially when they have had an accelerated aging. And then the real question is this whole idea of aging trauma or aging critical care patients. We did this review a few years back, but we repeated the data and seen the same thing, that there's definitely a difference between old and young up to about 75 years. And at 75, it kind of plateaus. And the whole point is, the concept behind this is that, if you live past a certain point, maybe your DNA and your genes make you more resilient, and maybe you age differently. And maybe we don't see that, and that's the reason why. So where do we draw the line? We can't draw it by age. I think that's really important. And I think, why should we distinguish different patients? Because age is really just a number. And hopefully, if one thing you learned today is to go away from just looking people by their age and bringing in this concept of frailty. Frailty has been around since the early 1990s, 92, 93, and it really took a little while to incorporate it. And we'll spend a little time on this word, frailty. What does it mean? It's not sarcopenia. It's not comorbidities. It's not something you can stand at the bedside and look at someone, put a thumbs up or a thumbs down and say, oh, they're frail or non-frail. Now, the extreme ends of that equation, you can, and they've actually studied this and showed that you can do that. And this idea of which life are you designing? Hopefully some of you laughed at this, but it is, which life are you designing? Does designing your life impact your aging process? And does that lead to components such as frailty? And I will tell you, the impact of frailty and older outcomes, started talking about it in 2010. And if you look at publications on this subject alone, I mean, it's insane how much is coming out, because we're learning that this is a better way to objectify people. It's really, and if you look at the different types of populations in surgical intensive care units or intensive care general, transplant, colorectal, trauma, orthopedic, cardiovascular, liver surgery, emergency trauma, and it's just a really hot topic. And this frailty really is a syndrome of physiological decline that affects all organ systems. And the most important piece of this whole slide is the last line that says it's independent of age and functional disability. And that's important. It's a state of vulnerability. And this idea over time with age, there's no doubt that your physiological reserve goes down. But the stress that hits you, whether it be a fall, an operation, a pneumonia, heart attack, an exacerbation of COPD, whatever it is that stresses you, the older over time your body is able to impact and deal with that, really it goes down. And this concept, think of a ball that's filled with air and you drop it to hit this ground and the ground is stressed, the ability for that ball to bounce back is its resilience. Think of a frail ball that's empty or deflated and you drop it, its bounce is going to be less. And that's what we're talking about. And it's this concept of aging versus frailty, it's not the same. And frailty is accelerated aging. And it can be something that we can slow down. And there's many components of it, including, physical function, social isolation. How does the cognitive side of your well-being impact that? And there's different ways we can do that. And of all the research I've done and studies, really, this is the most important slide that basically looks at frailty as an index marker on the y-axis, age on the x-axis. And this is a scatter plot. And that dark line across the middle of the screen is what frailty, I don't know if you guys can see my mouse, but this is, if you're above this line, you're frail. If you're below this line, you're not frail. But based on age, you can be old and non-frail, and you can be young and frail. I think that's important. We're looking at frailty at the age of 45 and above, and not even 65. And that's kind of what we're talking about. And so frailty is one patient-related factor that patients come to us that we are managing and identifying this. And how do you measure it? There's really 105 ways to do this. I don't think it matters, but the two core concepts of frailty measurements come from these two people, Linda Fried at Columbia, I think she's the dean. They're both geriatricians, and Ken Rockwood, who's a Canadian geriatrician who works in the EDs, and they developed these two types. Phenotypic model, which is a biological syndrome of decreased reserves, which looks at things like grip strength, nutrition, get up and go. The American College of Surgeons 5-step frailty. You've heard this concept, the frail scale. This is the Linda Fried who created this. And then Ken Rockwood talks about this deficit accumulation, medical, functional, social deficits that are all accumulated to go like this. And the deficit accumulation is 50 variables. And you tell surgeons or anyone to measure 50 variables, I don't think any of us are going to want to or spend the time to do it. And so this really wasn't feasible in our patient populations, even our intensive care. And this is where we spent the first years developing the emergency general surgery and trauma-specific frailty index. And I'm just going to kind of go a little off of the ICU for a second here, just to kind of understand and then bring us back to what we're here to talk about today. But we looked at this and we started studying the 50 component frailty on every single trauma and emergency surgery patient. And these were the frailty scores. And we said we cannot do 50 components. So we did a fancy statistical analysis and found those sections that are the most highest 15 variables that would predict frailty or non-frail, and then we prospectively validated these scores. And the only difference between the trauma specific and emergency general surgery specific, I wish I would have named it just emergency frail scale, but the difference is in the emergency general surgery you can see that hypertension, and in the TSFI falls fell out is important. But either way, it's important. The one that kind of gets everybody is so these are the 15 most predictive variables, how you measure frailty, and that's how we do it for every single patient who comes to our units or our center. This concept of asking elder adults if they're sexually active, a lot of people didn't use this scale because of this question. And there's data that shows that this is really a big part, and it's kind of funny how it fall out. But I bring this up not to be funny, but to say, like, this is a real component that I think tests something in the older adults. And so what about frailty and outcomes? Because I think this is simply comparing frail versus non-frail. And you can see a lot of people have talked about it in different ways, looking at functional independence, failure to rescue, our ability to get people back from complications, disposition. What if we were able to identify patients early on in their care and say their frail scale puts them in a box where we can put resources? And I think you can look at it, whether it be general surgery, emergency surgery, prehabilitation, outpatient. And once, it depends where this patient is. Is it outpatient elective surgery that's coming to the ICU? Is it someone who had an emergency trauma or surgery that's coming to the ICU? And can we still apply it? And really, for the last 9 years or so, we've tried to talk about how frail versus non-frail, take age out of it. Age is irrelevant. Simply being frail, you're more likely to be discharged to a SNF, 5 times more likely, failure to rescue, 3 times more likely, mortality, 3 times more likely, and then complications, and then long-term impacts, quality of life and whatnot. And so, what about post-discharge? Does this go on? And then you look at these things, and we looked at these things at 3 months, 6 months, and what did we find? Again, 30-day readmission, if you're frail versus non-frail, 1.5 times, 2 times more likely 30-day mortality. 6 months, this was in trauma and emergency surgery, but I'm going to bring you some critical care data to show you how important this is. Again, 6-month outcomes, and then even other things like functional recovery after chronic illnesses. Our admission film, discharge film, and change of our ability, functional independence measure is 26 points that rehab facilities utilize. The frail do absolutely worse than the non-frail. And again, we're actually presenting this at the AAST next week. We did a prospective multi-center cohort. Please don't take pictures of this and put it online, because this is not being presented until next week, so I don't want to get in trouble. But I just wanted to share some of the data of what we looked at. Could we apply it outside of our, because all that other data was from our institution. And same things we saw in index admission, 2 times mortality, 3.5 times more, like just simply by being frail versus non-frail. And then if you look at 3-month outcomes, look at mortality at 3-month outcomes, 7 times. So we got to make a difference, not only on the index admission, but long-term. And then within frailty, this is so critical, that as your frail scale went up, you actually had worsening. So there's like super frail, which is a new concept that hasn't been really vetted out. And this is another area where I think people need to start focusing on and thinking about this. And so we showed that TSFI could be applied, and we got the same results. And we think this is the way to go to measure. I'm not even talking about the pre-frail. What if you got a pre-frail patient that you could do some interventions or bring things forward that would allow you to make them better and pay more attention, put more PT, OT, rehab. I don't know how it is at your institutions, but here we're limited with a lot of the things that we can do because we don't have the resources. So if we could only apply them to those patients that needed them, and we were able to objectively measure which patients, I think that was important. We started looking at frailty in the ICU as well. And similar to, we found that as your frailty scale increased, you can see mortality is in blue, complications is in red, and discharge to what we call adverse discharge disposition to rehab or SNF increased with worsening frailty. And I think that's important. And again, we're not even talking about interventions, just simply frail versus non-frail. This study comes from London. It was just published this year, actually, not too long ago, in Annals of Surgery. And the recovery for critically ill patients, that are complicated by multiple organ dysfunction. Big thing we deal with, right? A third of their patients were geriatrics, and they defined it with a SOFA score greater than 5. When they looked at it, chronological age was not associated with development of MODS or MODS mortality. But when they looked at frail versus non-frail, you can see 7 times more likely to have multiple organ dysfunction and 2 times more likely to die based on frailty. And again, not chronological age. And these are in older trauma patients in the ICU. And then what about chronic critical illness? This study comes from Florida, and that group spent a lot of time determining risk factors for post-injury chronic critical illness. And again, 1 in 5 patients in the ICU develop chronic critical illness, and 4 times odds of chronic critical illness if your age was above 55. And they didn't take it one step further and look at frail beyond age. But here we go again. This patient population is different than, excuse me, what we're doing. And then what about frailty and survivors of critical? So you're in the ICU, and then you acquire frailty, or maybe you're not frail. How does being in the intensive care unit, how does that stress impact you? And this is amazing. Like, the majority of frailty is newly acquired amongst survivors of critical illness, meaning you are frail or you're not frail, you get critically ill, you get managed, you get discharged at 3 months, 45% frailty. And then 6 months later, 37% frailty. And I'm going to show you the next slide. You could have a low frail, and these patients were just distributed. So basically you could transition from no frail to frail, from high frail to less frail. So frailty is really dynamic, and it's a potentially reversible syndrome. I think that's so important. And then the big thing we all talk about, the D word in ICU, is delirium. What about frailty and delirium? Like, we get dinged for delirium, right? But are there patient level factors like frailty? This patient is frail. Does that predispose them? And Dr. Zendelman, also in New York, has talked about this for a long time, and better means for us to identify and treat. And we continue to do this. And we looked at this evaluation of delirium in geriatric patients undergoing emergency surgery. 145 patients prospectively analyzed over 1 year. And one of the things we had delirium. And what we found was, that the predictors of delirium frailty falls out, like polypharmacy, like comorbidities. So if you know you have a frail patient in your ICU, are you doing things for delirium, prevention? Because once you get the delirium, we all know what happens, right? It's really bad. The intubation, the admissions, the length of stay, the mortality, we know this exists. So I think this is one area where I think we continue to do this. And again, patient level factor, that we need to measure, objectify, and document. Every single patient now admitted to our service, our ICU, gets a frailty. And then what about polypharmacy? We know polypharmacy in our older adult population, 7 times more delirium. 42% of ventilator-associated delirium is attributed to polypharmacy. And then once you have polypharmacy in older adults, like what next? What do we need to do about it? And then this is where we start talking about non-pharmacological interventions, early mobilizations. And then our pharmacists, how can they help us? And are we doing things proactively to actually intervene, not only to identify, but to intervene? And I think we still got a long way to go. And then the physiological, immunological, hormonal status of frailty. Now let's take it to the basic science level. Back to this article I wrote with Dr. Scalea, but like the inflammation of injury, the inflammation of trauma, the inflammation of surgery, the inflammation of infection, how does that play with frailty? Because frailty is a syndrome of inflammation that can be brought back. And I think that's some of the things. And early on, we took trauma patients, all frail, non-frail, looked at things like inflammatory markers, endocrine markers, and here we are. We know that it's synergistic effect between frailty and the injury or the patterns. And we're actually looking at other things like response to inflammation, response to endothelial glycocalyx response in hemorrhaging patients. How does blood and plasma impact their glycocalyx, their resuscitation, their sepsis response? And these are things that are happening. And if you're a young scientist and you want a field to go into, this is the future. And I encourage you. And then the question is, what about COVID-19? We never all want to say the C word, but how did this impact us? And what we know over time is really people stayed in, right? No one went anywhere. And it impacted the elderly more than anyone. More isolation, more functional decline, more risk of injury. And now we have a huge subset of frail populations. And what has this led to? A saturation of ourselves. I mean, we're not even talking about a lot the resources and the providers, but the risk of falls, the risk of frailty, the resilience of our patients has gone down, and it's going to be a while before it comes back. I just wanted to kind of review some other injuries, rib fractures in older adults. I mean, we basically were used to admit every single person over the age of 60 with 2 or more rib fractures to the ICU, right? We had no objective. We were like, oh, they're old, put them in the ICU. And then this is not new. It's been around for 20 years. And people have talked about it as even as low as 45. With every rib fracture you have, they need ICU care. But do they all? Do we have ICU time? I mean, we learned this in COVID. Like, we couldn't put everybody in the ICU anymore. It wasn't a convenience anymore. And so we created this more recently, and I'm trying to get you guys to push toward this word of objectification, identifying objectively and now treating objectively. And we created the rib injury guideline score, basically looking at, age is one of the components of many. And if you score less than 2 or 3 to 9 or greater than 10, then that determines where you go. Greater than 10, you go to the ICU. Now we're looking at things like delta rig. How does rig change over time? And does that go? And we've showed that this works. Like, it was like 99% for sure that you could send an old person with a score 3 to 9 to the floor, and less than 2 discharge them. And we followed that. And I think that's important. We had no readmissions, no bounce backs to the ICU, and it's helping us with our triage and length of stay and other things that people are following us. And so what about pre-ICU nutrition? I mean, nutrition is a huge part of what we do in the ICU. Same thing. We know it affects a lot of patients in the older adult population, especially older adults. Poor wound healing, poor recovery, more likely to infection. And this paper basically, again, looked at predisposing factors for pre-ICU malnutrition. And there's many ways, excuse me, to look at this. But more recently, the geriatric nutritional risk index is where you can classify patients into good nutrition, mild nutrition, moderate or severe malnutrition. And we applied this to our frailty cohort. And what did we find? That 1 in 5 patients that are older adults suffer from malnutrition. And the feasibility of the geriatric nutritional risk index, if you had severe malnutrition and you were an older adult, your index admission, longer length of stay, more likely to get sepsis, pneumonia, adverse discharge. Look at the 3-month post-discharge mortality in this group. Severe malnutrition on presentation and discharge. It's unbelievable. Like, the data is just striking. And I'm like, we have to do something. This is how we're going to move the needle, improve our patient outcomes. And you have to keep a high index of suspicion. So maybe we can't change some of the patient-related factors, but we can document them, we can focus on them, we can try to. And so what about system-related factors? And so, surgeon volume, how many geriatric patients do you see? Do you apply geriatricians, palliative care, discipline, resuscitation, frailty pathways? How does this work? And who is to blame? Okay, so we talked about the patient. and blame is not really a good word, but what about our systems? Do our systems impact the way we are? And I think it's important to think about this. So there's no huge funding mechanisms for this subgroup of patients. And so what about hospital volume? We know that if you look at trauma, for example, and look at geriatric trauma population and how well you do and experience and patient experience, that if you have a low proportion of geri patients, you actually have higher failure to rescue, complications, mortality, readmission. And that's different than just having a low geriatric volume, meaning if you don't see a lot of patients, but a majority of them are older, then that is different. And we know proportion is greater than volume in its impact on systems. So, regionalization, that's something that's coming. I think we're talking about. So what does the future hold? Again, I think integrating geriatric principles. I mean, really the time is now, and we continue to talk. I think we've been talking about this for 10 years, and we're still learning to integrate these things. And is it us or who should be integrating? And I think it's important to think about what's the perfect time. And I try to bring this concept of what's called the silver service, which is, focusing on our elder adult patients. And there's a dire need for geriatric specific ICU resources, beds, PTOT nurses, therapists, physician education, and I think it's the clinical care pathways. And so let's just talk a little bit about resuscitation. I mean, fluid management in the older adults, challenging. 50% with the normal blood pressure have occult cardiogenic shock, cardiac and renal dysfunction, preload volume overload's bad, volume underload's bad, poor organ infusion. What's the ideal resuscitative fluid? Liberal strategies. I mean, we've done it for all populations. Have we looked at our older adult populations, our frail patient populations? And, what are different metrics or endpoints of resuscitation? And we kind of dibbled around with the shock index. They're on medications that slow their heart rate. They're on medications that lower their blood pressure. But how does this work? And I think when you look at blood pressure or heart rate alone in this patient population is really not the right way to do it. I think shock index is the right way. And then you can look at outcomes from shock index, predicting sepsis, predicting the need for resuscitation, predicting the need for interventions. And other people have looked at this as well, at different scoring systems, looking at just resuscitation, blood, for example, the ABC score, the TASH score, the PWH score. And again, what stood out? Lactate levels, shock index in our geri patient populations, and simple. The shock index, simple, your heart rate over your systolic blood pressure greater than 1. It just means this patient, the red light should go over you. This patient has something, we need to start paying more attention. And then the use of ultrasounds revolutionized ICU. And what about critical care ultrasound guided resuscitation in the older adults? Same thing again. What they found was critical care guided ultrasound, 47% lower fluid at 48 hours. 5 times less likely to be on a ventilator over 2 days. I mean, again, we should be applying these things to our subset, to our patients. And then beta blockers, which have been around forever. And, the first 2 studies are landmark papers on the use of beta blockers, but perioperative use of beta blockers in older adults. How is this playing in? And I will tell you that really how beta blockers impact our older adults is an area that is, again, very, very understudied, a great place if you're a young faculty researcher to want to spend your career answering questions. I think beta blocker therapy and mortality and outcomes and sepsis and geriatrics is really, and just having beta blocker therapy, we know reduces postoperative mortality as well as cardiac, which is a big thing we deal with in these patients in the ICU. And then what about geriatric pathways? How can we help our patients? How do we inflate that ball to get back? Because that's another concept that people think, oh, once you're frail, you're not coming back. But what about the early frail or the pre-frail? Can we make an impact in that subgroup? And I think that's important. It's really a multidisciplinary care. It's not going to be just one team, and it's intervene at every point. And there is lessons that we're all learning. I mean, just applying frailty alone. We looked at our center, 1,000 patients, and looked at what happened when we applied, just said, we're going to do frailty on everyone. We were able to show that we reduced complications, no change in our mortality, but just paying attention to, because our interventional phase is still coming, it's still happening. But just looking at our patients and saying frail, non-frail really changed our overall ability to understand and intervene earlier. And what about frailty screening pathways and identification pathways? So you identify frail, yes, frail, no. Hospitalist consult or medicine or geriatrics, social work involvement early on, earlier family engagement, post-discharge follow-up that's different than every other patient, post-ICU discharge follow-up, nutritional, speech, PT, language, order sets. Again, what did it show when you apply these frailty care pathways? Delirium reduction by 60% in the frail, length of stay reduction, 30-day readmission reduction, loss of independence. It's so important. Here's a great study looking at frailty screening initiative with postoperative survival. And they basically took these patients, basically looked at the frail patients and by the chief of surgery before the operation, and they intervened with surgical clinicians, the intensive care unit, anesthesia, palliative care, and each patient got an individualized perioperative plan. You can't do this for every single person getting surgery, but what if you did it just on the frail patients? Again, improved survival 4 times, not only on the short term, but the 180 days and overall over the entire year. Differences 3 times, huge numbers. And I think, what about just adding geriatric consultation? And I don't know, I wish I was in person again, but like, do you guys have geriatric consultations as part of your system? Can you call geriatricians? And what if you did do this? And the data will show, again, reduction in certain things because they pay attention to things that we may not. And it's these geriatric syndromes. But the reality is we don't have enough geriatricians, just like we don't have enough intensivists or trauma surgeons or a lot of things. And we really need more geriatric specialists. But the end game is going to be integration of geriatric principles and what we do. And I think that's where we're headed. And so, again, more about clinical pathways and how it changes older adults and delirium. Here's another one, geriatric trauma clinical pathway and rates on delirium by applying the things we talked about, geriatricians, pharmacists who are focusing on these things. The 4M criteria, great area to read and learn about medications, mentations, mobility, and what matters. This is a 2022 paper, and all our geriatric patients, they reduced delirium by 60%, improved goals of care documentation by over 40%. I could go on and on. I know it sounds like a broken record. Here's another paper. But the one thing we're not even talking about within frailty is, okay, we do all this, we identify the frail, but what about the patients that are from underrepresented minorities? How does that impact frailty and recovery? What about the frail versus non-frail and the impacts of 4Ms on that? And then what about the precise role of these patients? Who benefits the most? EROS protocols, early recovery after surgery. We're implementing the GROS, which is geriatric early recovery, and putting our patients who are geriatric patients on specific pathways that are protocolized so there's not fragmented individual care. And then we're almost there, I promise. Palliative care, this is another area I think that is important. How does palliative care implement into these patients, and what does it look like? And we know that palliative care reduces long-term readmissions and changes without increased risk of mortality in our older adults. And how you implement them. Can you call palliative care for every single older adult? In our institution, if you're over 65 and frail, if you're over 80, you automatically get some of these consults. And that's the triggers we use. And so we frailty screen everybody. It gets documented in their EMR. Who does it? The residents do it. Patient can't talk, they're intubated. You can talk to the family. A lot of times these questions, that's why we use the deficit accumulation. You miss one question, it's okay because it's not going to overall change it. Strict criteria for geriatric consultation, the 4Ms as we discussed. We do pre-op, post-op anesthesia, pain pathways for rib fractures, GRAS pathways, palliative, we're integrating, but we're still learning all this. And we're enrolling to kind of see where this goes. And the last section I want to talk about a little bit is just futility. Like when do we know? I mean, this is one that we all deal with in our older adults, and saying they're 70, we need to stop, or they're 80, we need to stop. I don't think that's appropriate. So there's no doubt that sometimes in our geriatric patients, they're beyond our capabilities, and we can't do more than we can predict, but we need to have objective data to have conversations with families and put objective numbers. And is there a point where we shouldn't be doing this? And this is kind of like high level stuff, but look at like certain interventions like emergency laparotomies, and those over the age of 65, which are in blue, 75 orange, and greater than 85. Look at mortality if you get an emergency thoracotomy. Maybe we shouldn't be doing them at all. Or if a patient has a pre-hospital cardiac arrest and trauma, 80% mortality if you're over 85. And if you're 65 and you get an emergency laparotomy, 40% mortality. These are huge numbers. And then what about like resuscitation with blood? Again, red is the PRVCs, yellow, over the age of 65, more than 10 units, 50 to 60% mortality in the TQIP data. Less than 10, if you get any blood, 40% mortality. And so I think it's important to start understanding these. We don't know the answers or where this is very high data in the sense of like 10,000 foot view. And what about objectification? Another thing we're presenting next week is just looking at futility of resuscitation measures that help us identify when we should stop. It may help us. And this is a futility resuscitation score that we're moving forward, and we kind of put together and we're validating to look at, hey, if we put all this together in trauma, but maybe we need it for other parts. What is the mortality? And if you score, can you talk to families? You say, look, mom, dad has an 80% mortality based on these factors. I think it's important. And then what about rescue from complications? And our geriatric failure to rescue score, again, another thing, looking at our ability to determine which patients by objective criteria are going to survive or not survive. And so we're really pushing toward objectifying all of this. So it's not this, I mean, there's no doubt that the bedside decision matters, but I think that we need to be better. And what it really brings us all down to is this, that look, aging matters, but frailty matters more. And you should be doing frailty in every single patient in your unit. Critically ill geriatric patients have worse outcomes. And we know that, but it's not just based on age. And I think we have to understand how to intervene. Frailty is dynamic and potentially reversible. And there's a lot more research that needs to be done. I think integrating geriatric principles in the ICU, the time is now. We keep talking about it, but how much are we actually doing? Do we have geriatric specific beds in the ICU with specific nurses? Do we have the resources to do that? Probably not, but can we start thinking and moving in a direction? And there's a lot more research for those young, hungry faculty and fellows and residents and students in the audience. Like, honestly, this is still open, and there's not a lot of places in medicine, but this is one of them, and I encourage you to do that. So I just want to thank everybody. That's my email if you have any questions. I'd be happy to take any questions now. So sorry, let me just find the Zoom share button here somewhere.
Thank you so much. I really appreciate that. That was a great talk. So my question for you is, have you guys built integration into Epic, like that automatically flags these, or how do you like get these consults? Are they based on kind of manual, like the team recognizing the frailty and ordering them, or is there like a way to automate this?
Sorry, let me just get back to me. I know I'm having a hard time getting out of sharing my screen. A couple things. I think one, you hurt my feelings because you said Epic and we have Cerner.
I'm sorry.
No, it's sorry. Here we found the buttons there. We have Cerner. We had Epic. We lost it. I think what we did in Epic, we actually created a TSFI. And I don't care what frailty score you use. I am obviously biased. I created TSFI, but it doesn't matter. And I think when you use the phenotypical, like grip strength, get up and ambulate, nutrition, the problem is a lot of our patients can't do that. So I really think it's got to be the deficit accumulation concept. We apply it into our H&P. It's a dot phrase. We put it in there. It pops up. You got to fill it out. You can't just bypass it. The residents put it in the admission H&P. And then where we take it from there, you know, we have one geriatrician that's able to consult with us in our institution. And we basically do one geriatrician who Monday through Friday, 8 to 5, and we kind of started really small. These are the only patients we're going to call you on. Come see them. And then what we learned over time, and we're going to write about this, is a lot of the principles that they actually put in place. Actually, we were doing them before we were calling them, and I think that's really the unique part of this. And so I think it's great to see that. So it is. I mean, but here's another thing, and I mentioned this earlier on. I'm going to say it again. You will be graded by our systems, by C-suites, by hospitals. And if you don't objectify the risks these patients have in the chart and show that it's not you, but this patient, no matter what you were going to do, had this high risk, you're not going to be able to show that you have the superior skills to take care of these patients, and it will hurt you in the long run. We're 5 to 10 years away from this, but for the young kids in this group, I promise you, you need to start thinking like this. And I think just looking and paying attention to it, it's natural here now. We don't even, in the beginning, it was like, oh my God, I'd have to ask 15 questions. I'm not going to do this. It's going to take me 20 minutes. And in reality, as we learned, it takes about 1.5 minutes to do. Some centers have implemented the nurses ask the questions that the patient can answer. Some centers, it's us. And so everybody gets a frailty within the first 24 hours. So.
Thank you. Is there any other questions from anyone in the group? This was a great talk.
That was easy. And Zoom's always fun. All the screens are off. I was going to make people turn on the screens, but sorry.
Thank you. This was great. I think frailty it's amazing with our elderly patient populations in our ICUs, how we're kind of seeing the consequences of all these. We don't really take care of trauma at the main hospital, but this is a system-wide conference, so we have trauma in some of the other system hospitals.
Yeah. And look, I could talk to you for an hour about nutrition in these patients. I could talk to you, but I mean, I presented my limited view, but if you look at frailty amongst just in general, it's wide open, but you will see the same story. You could take the word trauma out and just apply, you know, whatever you wanted in that word. it would be this. I mean, everything I read and Linda Fried and the medical geriatric literature, you go into it. I mean, that's where I got most of these ideas. Like, we need to apply this, back on us. So I don't think it changes any of that. So
Yeah, that was great. Thank you so
all right.
much.
Thanks a lot.
Great to see you. Bye,
Yeah.
guys.